Hey,
Alan.
how are you?
Great. How are you?
Good. Thanks for hanging out.
Oh my gosh, you live in the Brady Bunch house?
Yes.
That's awesome.
I'm so happy that you're able to guess what that was because last meeting, I think these younger people had no idea what I was going for.
I'm
So
like,
stupid.
what? Do you live in like 70s land or something?
Finally, somebody got it. How are you?
I'm okay. I'm okay. Making it through this week here in Texas. We've had
Oh,
crazy week. Yeah, I've been shut down for a week. Our hospitals have been almost shut down for a week, but they've been without water.
yeah. So you're in San Antonio?
Yep, it's been bad.
Oh my
But
gosh. So,
today was
so
better.
tell me what happened? What was going on?
So what happened was our power grids weren't weatherized for the extreme cold. We've gone through cold spells and snow before, but never so low for so long. Like it almost broke, like by 2 hours, it broke the record from 1951 or something ridiculous like that, when the population wasn't anywhere near what it is now. So the power companies had to manage the electric by doing rolling power outages so that they didn't fry the grids, because everybody was turning on their heat so high that we never do either for 5 days. And as a result of all of that fluctuation, there are a lot of burst pipes and lots of water pressure. And then the water storage tanks got contaminated, and the septic systems, like the public water systems, just were not functioning right. So we had various levels of people in San Antonio, and I live just north of there in New Braunfels, where they had either no power for days or no water or both. I didn't have running water in my house for 3 days, which was like, I never thought I'd really have to face that like scenario where I'm like, what would I do if, survival thing.
Right. So what
Yeah.
did you end up doing without any power and heat and water?
Well, they opened some warming centers, but a lot of people in San Antonio actually were very, very cold for a very long time. Their house was like 30 to 40 degrees. Even like one of my partners and some of my friends, they would go out to their car to warm up and to charge their phone, and then they'd go back in the house with the kids and huddle under blankets. And if they had a fireplace, that's great, but lots of people don't have fireplaces or gas. So a lot of people were very cold for about 2 days until the electricity got restored. It was terrible. So
that is so crazy. That's so crazy.
And then today was a beautiful 71 degrees out. Like snow's all gone, spring weather. It's gorgeous.
Like nothing happened. Huh?
Yeah.
Wow.
So our hospitals are getting back to work tomorrow.
So I did my fellowship in Houston. I was at Methodist.
I didn't know that. Yeah.
Yeah, and I think Houston was pretty crazy too. It was all of Texas, right?
Yeah, it's pretty much all of Texas. Yeah.
Well, I'm glad you're able to make it through and join us and
Thanks.
have this meeting today.
Yes.
So
I haven't done any of these with you before, so this is this is new.
Well, this is great. So what you got? Why don't you start by telling us more about your practice, because I know you've got like this finely tuned, well-oiled system. You're like a machine. You're a machine.
It is a work in progress. Thanks. So I finished residency in '95 at Georgetown, and I've been in San Antonio ever since. So I was trained laparoscopically and vaginal surgery and open. I had phenomenal training. I loved my residency training, but I have always leaned towards the surgery side of OBGYN. I got into it because I wanted to do surgery. And around 2008 or 2009, I was in a really large group practice, and robotics came along, and I picked that up like fish in water. Like that was my jam, man. That was what I was born to do. It just caught up with me. So I've been doing robotics since then. I left that group in 2014 to establish South and Central Texas's first MIGS practice. So that's my practice, Virtuosa GYN. And so I quit doing OB at that point, and I started I did that because I needed to get my clinic volume up to be able to get enough volume to keep up with my male counterparts that were doing all the GYN and modeling what the high volume GYN surgeons were doing. So I took the leap of faith and did that, and now I'm up to, I do about 650 surgeries a year, including minors. And I'm running at about 250 robotic surgeries a year. And I do very little straight stick laparoscopy anymore, but my practice focuses on the complex, the really difficult. I do a lot of fibroids, endo, large uteri, large ovarian tumors. I also do a lot of prolapse though, which is part of how this practice has worked, which is a little different than some other MIGs. I was trained to do, vaginal surgery, and I do sacrocolpopexies and slings and stuff like that. So that's.
Are you have partners, or are you on your own?
I don't have any partners, but I have 4 other providers that work for me. It's kind of interesting. One's an OBGYN, one is a family practice doc who's doing GYN in my office. She's not doing family practice. And then I have 2 nurse practitioners, and all of them are women. And with the exception of one of the nurse practitioners, they're all young women with young kids who wanted a part-time job.
Right.
So our practice model split out call from surgery from clinic. And these practitioners feed my surgery. They do all the primary GYN in my office and see OB patients. We use a laborist for deliveries. And so they don't have to do call, and they get the surgery volume started for me, and then they still get to maintain their licensure and practice while they're working part-time and being mommies.
Nice. That sounds like a beautiful setup you have. So yeah, we're going to be talking about, like, I guess, tips and tricks for the big uterus, right? So yeah. I guess, so usually, like, you get a patient come in, comes to the office complaining of, referred for heavy periods, probably got some degree of anemia, and, main complaint is she's got heavy periods, but I don't know if they're heavy because they've always kind of been like this. And, I pee a lot, I do pee frequently, but I also drink a lot of water. That's usually what I hear. Yeah. So, like, how do you approach these patients when they come to your office?
So one thing that I do that helps makes the time from consult to surgery really short in my office is I require them to already have sonoimaging when I see them. Any patient that has menorrhagia, before I even see them, they've booked and have imaging. So I see them for the first time already knowing that they've got fibroids and a large uterus and kind of on the spot.
So if it's a new patient that schedules an appointment, do you already order a pelvic ultrasound, or if they haven't already had one?
Yeah, if they haven't had imaging yet, that's a standing order in my office for a diagnosis of or complaint of heavy bleeding or menorrhagia.
Okay.
So, and I got that idea from my general surgery friends. When I was looking at shifting from doing general OBGYN to shifting to a surgery-based practice, I was like, how do I go from operating half a day or 1 day a week to what my general surgery friends are doing? They were doing 3 days a week. And I was like, how do you do that? And what are your ratios for visits to surgery? And my surgeon friends were like, 3 visits to surgery. And I was seeing like 50 because I had all the OB and primary care and everything. So they were like, yep, everybody comes in, they're already, if they're coming in for a hernia, they've already had their imaging done. If they're coming in for, joint stuff, it's already done. So gallbladder, it's already done. So that's one big thing that I've done that's helped. So I'm not starting just with a physical exam and a complaint with a patient. I'm like, pretty much if they're coming in complaining of really heavy periods and bleeding, I'm going to get imaging at some point. I need to know what's going on in that uterus and that pelvis. So we just do that up front.
Okay. So you got this patient, she's got a big uterus and a little bit anemic. So how do you manage the, the anemia and optimize them for surgery if they're running a bit low? Does that concern you, or do you what do you do about that?
It does. That's a great question. So so we do finger stick H&H or finger stick hemoglobin in the office, which isn't as accurate as a CBC, but I can get some sense. And a lot of patients are sent to me from the ER. So if they're not already on an oral iron, I use the glycosylated versions, like Integra is the one that I usually think of. So they get into the bloodstream and don't upset the gut so much, and they'll raise the H&H faster. So Integra, Niforex, what are some others? There's like 3 or 4 glycosylated brands on the market. I do have a hematologist, and several of them that'll work with me and do iron transfusions if the patient is stable enough to get it up by doing iron transfusions. I mean, if they're seriously low, of course we admit them and get them transfused, and then they come to me. But I used to not operate on Jehovah's Witness patients because I had a thing about, you know, just a moral dilemma for me about an ethical conflict between their wishes and mine. So I just chose not to until I started doing robotics. So I used to say my patients had to have a hematocrit over 30 to operate on them to do a hysterectomy. Now I push it down to 27, sometimes 26. Because
so that would be like a hemoglobin of like 8 or 9?
8 or 9. So the hysterectomies that we do and the approach that I take, even with a big uterus, is to look at the 4 corners, which are the blood supply, and to secure the blood supply first, and then do everything else. And so even our big uteri usually have less than 100 cc's of blood loss. So, and I didn't do that just over, you know, I didn't do that in my first 50 robotic cases, and I never would have done that when I was just doing straight laparoscopic. I wasn't hemostatic enough. I wasn't anywhere near as talented as you are with the straight stick, or confident in that. But with the robotics and having, you know, hundreds and hundreds under my experience belt now, I finally was like, you know, it's wrong for me not to offer this to Jehovah's Witnesses. They need a bloodless surgery option or a low blood loss surgery option worse than anybody. So that's how I handle it. How do you handle it?
So I don't know, you know, you get these patients and their uteruses are a bit big and they're a little anemic, and you know, like I can do them big, but like I just do like 3 months of Lupron to try and shrink it and optimize them, and that way the fibroids are smaller and softer the majority of the time, and then their anemia gets better and it's easier to manage. You know what I mean? Like I think a lot of the surgeries that you guys that I post, that's after 3 months of Lupron, and it's like 30 to 50% smaller than what it came in with. Like I don't like doing like I can't do a laparoscopic hysterectomy in somebody who's, you know, abdomen is full of fibroid and there's no wiggle room, and you know, do a myomectomy, pull it out and address the vessel. I just can't do that because it's too high risk for me, and you know, I'm not that brave, you know. Well, so I think I give a lot of Lupron. I haven't used the Orihan yet. It doesn't make sense to me, like, you know, giving a medication that, you know, shuts things down, and you give hormones to offset the side effects of something that you've done, and those hormones you wouldn't normally give to somebody who's 35 years or older anyways, you know. So I haven't really found a patient for that, but like for the majority of the patients I do Lupron. But like I found myself starting, like since I got to Florida, like I've been talking to the interventional radiologist a lot. And I've actually sent a couple of patients to them because, you know, these patients are from the ER, they're self-pay, and I know that I'm going to lose them for follow-up, you know, so I get interventional radiology involved, at least to try and help decrease the bleeding so that I can see them in the office. But I think the majority I see one time and they decline surgery anyways.
That's interesting.
Yeah,
so we have a little different system in Texas for the unfunded than what you deal with, it sounds like. So we have emergency Medicaid that the hospital will get from the state for anybody that's admitted emergently through the ER. And I have a call contract with the hospital that includes taking care of the unfunded. So it's actually pretty straightforward if somebody's anemic and bleeding and coming in through the ER to admit them, and it's just easier for me to just get them done. So we usually just admit them, transfuse them, get them done. And then I include the post-operative care in that. I just tell them, if they were seen by me that way, then it's important for me to see them for post-op, and I don't charge them. That's included, kind of like it would be a global. And
Oh, that's true. Well, that's nice. Yeah, so I think I'll do like 3 months of Lupron if the uterus is really big, and that gets it down
Yeah,
to a manageable size
that's a
at
cool idea.
99% of the time, and their anemia is better. And then, so I have a question. So you were doing straight stick laparoscopy, you switched to robotics.
Mhm.
So how do you, like, when you're doing big uteruses, like what are the advantages of robotics? Because, you know, I did robotics a long time ago with my fellowship,
Yeah,
and my thought from when I was doing it, I always thought that like using the robot would be more difficult because you can't, once your ports are placed, you're kind of stuck with them. And I wouldn't have had the ability to kind of go back and, you know, kind of, if my ports were too low, it would screw me up for the whole case. But
yeah.
things are different now. So what are your
Well,
thoughts?
so a couple things. One is I like having two hands, and that's a big difference between watching your video and how I operate. I usually operate with a bipolar device in my left hand and a monopolar in the right. And then I do a fourth port that's an assistant port. So my assistant's doing the Davison grasping to provide countertraction or doing the suctioning. And so having a grasping bipolar device and a monopolar to kind of zap
Yeah.
gives me the dexterity that's similar to what I would do open.
And that's what I was doing in my fellow. I did that too, like monopolar scissors in one hand and a bipolar in the other when I was
Yeah.
in robotics.
Yeah, so that's advanced now to the vessel sealer extend with the faster generator. So now it seals.
So now you can do a hysterectomy like 14 minutes. You can do it in 14 minutes. That was awesome. Okay, go on.
But not one like you did on this really big one. So, you know, the big ones are still a challenge, but it is much faster. But the ability to control the blood supply and the dissection without having to switch out, I think that's helpful. And then, you know, I don't think having the fourth port is necessarily a robotics thing. I think that's just having that fourth port where you can get to that other side easier and port hop. Like when you were doing robotics, the XI wasn't out, I don't think. And so you couldn't port hop. So I usually put my scope port through the umbilicus. So I always do a cut down. I always do it through the umbilicus. It's easier to excite. And unless the patient's had like a tummy tuck or something, or they're really tight, that visualization from that angle is fine. And then once I'm in, I decide, do my ports go down where I usually put them, which is like a centimeter lower and lateral, or do I need to bring them up above because it's higher and I need to get around? But I switch out my bipolar. So if I start with a really big uterus with my vessel sealer in the left hand and take down the left supply, I go all the way down to the uterines. And then I put the bipolar in the opposite hand. I put it into the right hand and take it all the way down. So that's one trick that I do with the new equipment on the robot that I never did before. That's made big uteri a whole lot easier with the vessel sealer. It makes it easier to control the bleeding and grasping. I think I wanted to ask you about positioning because it's really hard to tell like how far your T-berg was on that video or what you're used to doing. And it can vary from patient to patient. Like, you know, some patients, it looks like they're not in much T-berg, but they're in 30. So I usually operate in 30 degrees of T-berg, and it's easier to reach a cuff sometimes on a big uterus if it's tilted a little bit. So
no, my surgeries are a little weird because like, so I'll usually, you know, I do a left upper quadrant start in morbidly obese in patients with previous surgeries.
Right.
So left upper quadrant start with my 5mm air seal port.
Yeah.
And then I'll put either a 3mm scope in the umbilicus and a 3mm left lower quadrant port, or a 5mm umbilical port for my scope, and then a 3mm grasper.
Okay.
And my grasper has to be high enough to be able to clear the fundus to grab the right adnexa. So as long as I'm able to do that, I'm able to complete the case that way.
Yeah.
And then the scope varies on the assistant I have. If I think they're going to fracture the fiber optics, I'm going to use a 5 millimeter scope. Sometimes they're like bending it and it scares me. So that's what dictates whether I use a 3 or 5 in the umbilicus. But like I'll start at 12 millimeters, mercury for pressure, and then I'll start with minimal tilt. And then as I need more, I'll increase pressure and increase tilt. And then after I'm done using it, I'll have the anesthesia go back to less pressure and less tilt.
Yeah, that makes sense.
Because I don't know, I think like being minimalist is important for that stuff too. Like I've noticed less pain when you have less pressure. So like, patients complain of, oh, my abdomen feels like I've done 1,000 sit-ups. And I think it's because we've always operated at 15 and it stretches the muscle. So operating at 12 has less pain associated with that. So I've been trying to be good about that. And then surprisingly, I'm able to get everything from that left upper quadrant port. So like, taking down the left and right uterines and do everything, even suture from that left upper quadrant port. It doesn't really make much sense to me either. But because I always thought that I'd need a right lower quadrant port to address the right vessels.
Yeah.
But for the majority of the cases, like for big cases, like I'll start with the left adnexa, take down the fallopian tube, uterovarian round, and try to get down as far as I can, maybe take the vessels down, but not cut them. And then I'll start on the right side, but sometimes it's too big to reach. So now that I took down my left adnexa, I can rotate the uterus up and address it from up top, like rotation.
Yeah, I saw you do that. I think that's a really important point to emphasize for the surgeons that are listening. You demonstrated that in that video really great about using that manipulator to provide countertraction and rotation to
right,
get.
I'll spin it. Spin it and I'll put the bend up so I can make the bladder flap and rotate the whole corpus and even take down the uterines from 12 o'clock.
Yeah, we do that too. I think that's a really cool trick, that flipping the manipulator. And that gets that bladder flap, that anterior dissection right up in your face.
What manipulator do you like?
So I used to use VCare. I'm a delineator girl. So I switched to delineator a while back. It's got a roomy cup on the end of it, like the Cole cup that's on the roomies, but it's shaped like a VCare. It's a Cooper Surgical product. It's heftier. It's for these really big uteruses, it's the handle doesn't bend quite as much. It doesn't give, but it doesn't have a port through the center of it like the VCare does for doing chromotubation. And when you're using the hook, it doesn't have that groove that you're using the hook to do the colpotomy in.
Right.
So, yeah, but
I used to use Roomy.
Yeah.
Yeah, and then I switched to VCare, and I don't know, it was just one of those things. But yeah, I think that's good. For that case that I had, so I had a very difficult time reaching and exposing the right vessels, and I lost control of it, and it was spurting.
I know, that was scary.
Yeah, I was cool. I knew it wasn't going to be as bad, like a garden hose. It wasn't as bad as, I knew I got it like partially, but one thing that I should have done in that case, and I've done in the past, and I actually learned it from one of the members in our group, take the uterine manipulator. So you do your colpotomy. So I injected vasopressin in the vagina.
I wanted to ask you, what was that? Yeah.
So, that was a big uterus, and those damn vaginal vessels, sometimes those things bleed like a uterine artery.
Yeah, they do.
And it freaks me out, and I start chasing it and getting all crazy. So for cases that have kind of like I am expecting a lot of blood loss from those vessels, I started injecting vasopressin because I always have vasopressin on standby anyways.
Yeah.
Like if I lose control, I'll just inject the uterus with vasopressin, especially when you've got those pedicles sealed and you're trying to manipulate the uterus to get better exposure.
Yeah.
When you touch those corners, they open up, and that's when those vessels bleed.
Yeah.
Once those vessels bleed, you have to rush and take those uterines down, right?
Yeah. Yeah.
So like you got to be very careful, like touching the top. And if you open them up, you have vasopressin on standby. You can just inject it like you were going to do a myomectomy, help decrease bleeding, right?
Yeah, I'm going to take that trick. So were you using just a spinal needle there?
Yeah. So I get a spinal needle, pop through, and I just grab it. And for that, since it's there, I inject the vaginal, like the incision where I'm going to do my colpotomy, just so those vaginal vessels don't drive me nuts. And I think it's pretty significant because the bleeding that you can get from that is scary.
Yeah.
So if I were to do that case over again, I would complete the colpotomy. I'd start my anterior and posterior colpotomy and leave the right vessels there.
Okay.
And then pull my manipulator out, seal the vessel, complete the colpotomy, and take the right uterines last.
You know what? I can see an approach for that. I do the opposite. I get all the vessels first.
Oh, I think that's the traditional way. Yes.
Yeah.
That's the preferred way.
In fact, I don't even cut the left uterine until the right one is sealed. Like I seal both of them before I cut either of them, so that all four corners of the uterus are taken down. But even with that, like you mentioned, sometimes you get this vaginal or that little bladder branch or uterosacral branch, and they bleed like crazy. So it was fun watching you deal with that. I thought that's a good lesson to watch. Like we think that's such a huge amount of blood loss, but really it isn't. It feels worse than it is in the moment that it's squirting right at your eye, you know?
Oh, I actually cleaned that camera multiple times.
I was watching.
Oh God, it was.
You did great. You did great.
Yeah, but like doing your colpotomy, like, you know, sometimes like I'll seal the uterines, and even just sealing them, it starts bleeding, you know?
Yeah. Yeah.
So
yeah. I've never found a bipolar of any kind that was wholly reliable on the uterines. And I don't know why, but no matter what I've ever tried, ligature, harmonic, BSE, vessel sealer, bipolar, PK, whatever, they all have that risk of something breaking loose. And, when I see that lumen, I just grab it, seal it.
One thing that I started doing, and, like taking uterines, like, we try to skeletonize, and the more you skeletonize, the easier it is to control. Like, how people take the uterines at its origin, open up, they find the origin and take it. So I've kind of done something similar where I'll make a slit right above the lower uterine, right at the lower uterine segment, just around where the uterus sacral is.
Yeah.
With my monopolar, I'll cut a window and slide my jaw in.
Yeah. Yeah.
To me, that's like a ghetto uterine artery skeletonization. Looks quick. So you just make a little window, like a cut, and if you can like get your vessel sealer like this as opposed to like this,
right?
Get behind it.
Yeah.
You can control those vessels super quick.
Yeah.
The only problem is you can also cut into a vessel and cause bleeding.
So I wanted to talk a little bit about that, because that's something that we've all dealt with, right? Is like nicking a vessel and then trying to go after it. And it's not necessarily something that I saw in your video, but I see it a lot with newer surgeons where they like keep digging and digging instead of just creating the exposure. Like sometimes if you just bite the bullet and cut through it and give yourself the exposure, then you can see the lumen and get it, instead of like digging through the blood and the nick. So I wanted to ask your thoughts about that.
Yeah, so like I just make my window, try to get behind the vessel, try to slide my jaws behind the vessel and in front, and then start working from there.
Yeah.
And if I get into bleeding, you just keep going. Like I always try to stay above the uterus sacrals.
Yeah.
Right. Because starting up high, if you lose control, you move down and you're not so scared of getting the ureters.
Yep.
And then I think, after like it takes forever if you approach laterally and just keep sealing. And then, that can take forever. You know what I mean? No matter how well you skeletonize.
So what I usually do is I look at the cup where you've got that great cephalad pressure from the cup. So you get kind of a table where the vaginal skin is pulled over it and the vessels are coming across it. And I just take it right there inside the cup. right straight down on that table that's created from that pressure from the skin stretched out across the cup. So I don't go down the uterus quite as tight as you do. I just take it right at the inside of the cup. You're looking at me confused.
No, I'm going to try that. I'm looking at it like, huh. Yeah, I'm going to try that next time. So you go straight at that cup.
Yeah, so if you're inside the cup that you don't have ureter, because the cup, if you've got, the key is the really good cephalad pressure, but you demonstrated that in your video really well. And you even took it down to fascia, like when you did your bladder, just such a beautiful dissection, you took the bladder down and you could see the white shiny fascia with the vessels coming across that. And I would have just gone right inside the edge of the cup, straight down on that table and sealed. That's how I take my vessels.
And then you're done.
Yeah.
I'm going to do that. Thank you. I'll try that.
Don't blame me if it bleeds.
Because it always seems like, if this is the cup, it always seems to me like it's not like this, but like vessels like that are all around. You know what I mean? It is like the whole side.
It is. So when you use that table space, is what I call it, you've got your primary vessel coming in, but it gives you a chance just to seal and cut and seal and cut and seal and cut. And I take it down, I use a scissor, but you could do it with, you were using a harmonic, right?
No, the ligature with the elbow.
So I take it down so you see that white fascia all the way around the cup before I do my colpotomy on both sides. So you can get all of those little stinkers that are like the small vessels going every which way. And I stay inside the cup. Like you don't want to do it outside of the rim of the cup because then you get into ureter territory.
Right. I'm going to re-watch my videos and see what you're talking about. I'm going to try that. That's awesome. I usually try to do a colpotomy before taking the vessels too sometimes.
Yeah.
Just to kind of get that endopelvic fascial plane better developed.
Yeah, I'm a chicken.
Right?
I'm a chicken for getting the blood supply first. I've seen these beautiful dissections where people go anterior colpotomy and posterior colpotomy and all. I mean, Devin Garza does that, I think, or had a video about it, and then gets the vessels last. And I'm like, I'm chicken. I'm like, take the blood supply, get it controlled.
I think it helped me, I guess, find that bladder. The bladder plane and isolate the vessels better sometimes, at least when I do it anteriorly, but it doesn't, I don't do it with every case.
So you reminded me, there's another trick that you did on this video that I thought I had invented, and then I saw you do it. I'm like, darn it. So it's the trick where you can't flip the uterus up to get the posterior colpotomy because it's too big. And you can't even reach around it no matter how you flip the uterus. So the place where you took the manipulator out at the end of the colpotomy and you just did the colpotomy freehand on the back of it.
Right.
That is how I do all my big uteri. And I usually have my assistant put her, she puts an instrument, or most commonly the suction irrigator. We use a laparoscopic suction irrigator and it's plastic. She puts it underneath there to protect the bowel for me, and it gives me a line to cut on with my scissors when I'm doing the colpotomy. But you did it using the ligature.
Right.
That's a big, if people can get that, it saves them so much time.
Oh my God, that trick, sometimes it's impossible to complete the colpotomy. And, the uterine manipulators, we think it's so helpful, but sometimes it limits exposure.
Yeah.
Especially if we're not the ones controlling it. You know what I mean? So, yeah. Another thing is when the back of the uterus is stuck to bowel.
That's crazy. Yeah.
Right? Like if you have a lot of bowel stuck to the back of the uterus, taking down the uterines, completing the colpotomy, taking down the adnexa, removing your manipulator, flipping the cervix up and taking the bowel from... so now the uterus is hanging up there and taking the bowel adhesions last. That's another time that removing the manipulator is helpful.
That's a great point. That's a great point.
So how do you take out these big uteruses?
So I do excite extraction through the umbilicus. And I also want to mention something about pain control. I've been an Exparel person for 6 years. I've been using Exparel. I'm a big fan. My anesthesiologist started doing tap blocks on these patients that we're doing the excite extractions on. And they're doing the tap blocks with my diluted Exparel. And these patients have like almost no pain postoperatively. They don't need narcotic. And the rare cases where I do a vertical open because the fibroids of the uterus are so ridiculously large. Even those, the tap blocks have been working really well to get patients out of the hospital and moving faster. So that's a big trick for lowering narcotic use, but also moving towards same-day surgery. So most of my cases are same-day surgery, even these big ones, but part of that is the pain relief and them being able to eat earlier. So
anesthesia does the tap block with the bedside ultrasound prior to rolling back?
No, they do it in the OR. So they put the patient to sleep and they bring the ultrasound in the OR and do the tap block before we prep and drape.
What do you use for post-op pain control?
So preoperatively, they get GABA and oral Tylenol, and then they get a dose of Toradol in their arm as they're coming out of the OR. And I give them one hydrocodone option in recovery before they go home.
How much do you give them in the holding area?
I have no idea because my anesthesia orders it. I'd have to look that up. But my prescriptions that they go home with. So my patients go home 4 hours post-op. I do an H&H at 4 hours on my hisses. I'm just too chicken to not, and I just check for stability. So they go home on scheduled ibuprofen or other non-steroidal for the first 2 or 3 days. And I give them 10 Tylenol number 3s. Most of them don't use any of it or use 1 or 2. So I have a backup. I don't, I'm in private practice. So I don't. No,
I get it.
Yeah, I don't get called.
And then the Exparel.
So Exparel with non-steroidals is by far the primary. And for my patients that can't do a non-steroidal, it really makes a difference. Like Tylenol.
Gastritis?
I see a little bit of it. Not much of it. Huh?
No, the ones that can't, they're contraindicated because of GERD? Is that why?
GERD, or they've had ulcers, or they've had gastric sleeve bariatric surgery. Those patients aren't supposed to get it either. Or they've got an allergy to it. But that, so the excite extractions, I open them up pretty large. Like I'm not they're so exhausting to me. Like they wear me out on a big uterus that takes a long time.
You see that?
Yeah, you got a callus.
I got them on both, but it's from too much. Yeah.
So I open up, a 3 centimeter incision in the umbilicus to get out the large uteri. How do you do it?
So like, I don't know. I've done the excite, applied medical, table and pulled the chicken breast or whatever out, and I just can't get myself to extend an excision to remove it when I got a perfectly good vaginal incision.
Yeah.
So it's not easy. It's not quick, and it's a pain in the ass.
I know, but it's so good for the patients though, right?
Well, I think so. Not good for my thumbs, but I'll I'll put a weighted speculum, get the uterus, and I'll do the excite from below.
Yeah.
I'll start, and then try to maybe put a tenaculum on it and then push it in and just try to get as much rotation as I can. And while I'm down there pulling out fibroids, if I can, I've tried to, cut a wedge, clamp it, and then cut a wedge again, and then just take out wedges. That works for some, but it just depends on. And then sometimes I'll try to cut a slit into the uterus to make it kind of unfold a little bit.
Yeah.
There's a million things that I've tried, and none of them are
fun,
time efficient. It always takes longer than the actual hysterectomy. I don't know, just a pain, but I don't know. It comes out, like that last case, it took 15 minutes to pull that thing out.
That's not bad for that big a uterus.
Oh, but I cut a big slit and like cut some of the fiber so it kind of folded out a little bit. So
Yeah.
the big piece, the only reason why it came out was because I cut inside to allow it to come out. But I was pulling fibers out, and yeah, it was a pain in the butt.
Yeah.
I can never, I know the Excite makes sense and it'll make it quick and easy, but I don't know. Like I'll do a mini lap for myomectomies and they still
Yeah.
go home. You know, I inject a lot of local, but
Yeah. They
um,
still come.
yeah, but like the case is done. Like for myomectomies, I'll do my mini lap after I find the plane and then pull it out and then suture it through that mini lap
Oh, that's nice.
versus, well, for the majority of the time, versus if they're really big, but then, you know, smaller ones, I'll do it laparoscopically and then pull it out through the posterior cul-de-sac. I make an incision in the posterior cul-de-sac for a bit.
Yeah.
But yeah, like, I don't know, it's hard for me to extend the incision, and like I'm still trying to
Right?
soul searching here. You know?
We just try so hard not to make those bigger incisions. Yeah,
Yeah.
I know. It's painful.
But no, I get it. Like if I don't know if like I had like 10 cases lined up, you can't really do that. You know what I mean? But at the same time, that would suck if you can remove it vaginally, and you know what I mean?
Yeah.
I don't know. I'm still figuring it out in my mind, you know.
Yeah, me
So
too.
for post-op pain, like I'll do I give them gabapentin the night before.
Okay.
I think it takes a little while for it to reach steady state. So I
Yeah.
start the evening before, and then I can see what the reactions are. Like I give 300 the night before. And the morning of, I'll give Tylenol 1,000 milligrams and 300 gabapentin before coming to the hospital. And usually it helps them sleep the night before surgery.
Good
And then I
point.
can see if they're like snowed or, you know, any
Yeah.
problems the morning of, because sometimes they take like Xanax or something, and it, you know, once that happened, like she was like snowed. So that was the one time it, you know, the anesthesia was like, oh, it's probably not a good thing, but I'll do the Xanax or the gabapentin Q12 hours for 7 days. And then I'll do Toradol. I keep them overnight for 23 hours. And that's just because I'm scared. And then
I hear you.
I should be moving towards sending them home, but there's some patients that, you know, like nausea after surgery, and
Yeah.
I'm still working on that too. I'll do 3 doses of Toradol, and then I'll do Celebrex
Oh, cool.
Q12
Yeah. Okay.
because it doesn't increase your risk of bleeding, and it doesn't have the gastric irritation.
You know what? I had not considered those points. That's a really
And if you do the GoodRx coupon, you get 16 Celebrex for like $11.
wow. Really?
Yeah, GoodRx. You got to
Yeah.
print out the coupon.
Okay. I'm writing that note down. I'm taking that. So
Sometimes
wait, do
you
you
have to
give
get
them
off.
narcotic at all?
No, I'll do gabapentin, celecoxib, and then Tylenol 500 Q6 around the clock for 2 days, then as needed.
Okay.
And I'll load those incisions up with local, with
Okay.
ropivacaine 1-to-1 with injectable saline.
Yeah.
That's my ghetto tap block.
Yeah.
And then yeah, no narcotics.
That's awesome. So when they're in the hospital overnight, do they have narcotic orders or no?
No. If you
That's
put
awesome.
if you put a PRN narcotic order, they get narcotics
Give
because the
them.
nurses.
I know.
But
I know.
they don't need it. But yeah, and it's not a matter of patients going home having pain and pushing through it. It's pretty effective. Like they don't, you know, it's good. Like with you and your Expero, I think that would be like icing on the cake. Like you
Yeah.
wouldn't have to do the Tylenol 3s.
You know what? I think I might consider switching to the Celebrex with the scheduled Tylenol like you're doing, and the
Yeah.
GABA. I'm not using the GABA nearly as much as maybe I should be.
Yeah,
Did you say you do that scheduled afterwards too?
I do 300 BID
Mm-hmm.
for 7 days post-op.
Okay.
And the therapeutic is TID.
Right.
So BID at around 10 hours, they start feeling a little bit of pain, and then 12 hours, they get the other one and it pushes them through. If you do TID, there's too many, I guess, more side effects.
Yeah.
Sleepiness. So the BID 300 is perfect.
Perfect. I love that. Okay. I like that we're both working towards small incision, making it easier for the patient, get them out of the hospital and home as soon as possible, off narcotic. I mean, that's just, it's so much better for the patient.
What about your Foley? Do you see your Foley immediately post-out?
Mm-hmm.
Yeah.
I do, because then they're waking up from anesthesia. It gives them enough time to fill their bladder to do a voiding trial before they go home. So without having to backfill the bladder.
Yeah. I got to do that too. I've tried removing the Foley sometimes, but then I don't know. I don't know. I got to work on things. I've got some things I got to fix. So.
See, that's why these conversations are great.
Yeah. So have you tried Lupron?
I use Lupron very extensively in my endometriosis patients, but I don't really use it on my fibroid patients. Most of them, I don't know. I guess I just get it done. And most of them, if they're acutely anemic and have been transfused, I'm like trying to get them to take Lupron or pay for it or go through the side effects and all of that and be patient for 3 months and maybe have bleeding in the first and all that. And I just haven't. Just from the surgery.
I use Lupron way more for fibroids than I do for endo. I think the majority I use it for fibroids. And so next patient where you've got a big uterus, so you got to get the Lupron samples, one every month.
Okay.
From the Lupron site, it's free. Well, you got to talk to your Lupron rep, but get the Lupron samples once a month.
Okay.
Right? Start at the first of the month. And then the next patient you have with a big uterus and you'll be scratching your head thinking, oh man, this is going to be a pain.
Yeah.
Hit her with Lupron for 3 months.
Okay.
And iron, oral iron replacement.
Yeah.
And schedule the surgery for the third, after 3 months or 1 month after that third dose.
Okay.
And the uterus will go back to like a nothing uterus. Like,
easy.
Oh yeah, that's kind of big, whatever,
Yeah,
and it'll be the easiest excite ever. It'll be the easiest excite you've ever done.
That's what I'm looking forward to, because they just kill me. Those hard fibroids, oh my gosh.
It turns into like mush, It's not so good with myomectomies though. Like for myomectomies, like I'll do like 1.5 or 2 months.
Yeah.
If they're anemic, because it distorts the planes. But for hysterectomies, 3 months of that, and it's
make it easier.
Makes your whole life easier.
Thanks, Ellen.
You're welcome. That's the takeaway. What about adenomyosis? You get a lot of that?
I see a ton of that. And it is so underdiagnosed by our radiologists.
Right.
Like massively. Like they'll send me a sono from the hospital, from the ER with like a 13 centimeter, 14 centimeter size uterus and say, it looks normal. And I'm like, I'm calling BS on that.
Endometrial subendometrial cystic lesions, normal, heterogeneous, normal.
Yeah. I'm like, no. And I gotta say, I'm not perfect in diagnosing it, but over 95% of what I call on my imaging is confirmed on pathology. So I'm not just like making it up and taking out uteri, but we're seeing huge amounts of it. And I will tell you that I have done some experimental assessa on adenomas successfully. So I haven't found a good way to treat like the whole uterus. Just nothing works.
I got a secret for you.
Hysterectomy. You got a what?
I got a trick for adenomyosis.
Okay, tell me. What's your trick?
It's gonna screw all of us up. Everybody who's here, it's gonna screw you guys up because, like, I think I found the secret recipe to treat adenomyosis without surgery. Yes, what is it? Without a hysterectomy.
What is it?
2 months of Lupron.
Okay.
Sneak in a Mirena. Continue the Lupron for 1 more month.
Okay.
And then let the Mirena do its thing.
And you see the pathology on the myometrium get better, or just the symptoms?
Everything. It's like you put a Mirena in somebody and their pain is better.
That's
so
amazing.
Like, if you put a Mirena in somebody with active adenomyosis, it's like stabbing him in the uterus with a knife.
Yeah, they hate it.
It's horrible.
Yeah.
So 2 months of Lupron to calm those cells down and quiet everything.
Okay.
Sneak the Mirena in when the uterus isn't looking.
Love that.
And
It
then
works.
you got to do 1 more month of Lupron because it takes a little while for that Mirena to start leaking its
Okay.
hormones. And then
Okay.
take the Lupron away, and the Mirena will continue and do its thing.
So how many patients have you done that successfully in?
So many. Everybody with adenomyosis that doesn't have anything else.
Childbearing.
Exactly. Yeah, it's just everybody with a uterus like 10 to 13 centimeters with chronic pain, heavy periods.
Yeah.
And it's not I mean, I've lost so many hysterectomies from that.
That's okay. We're not in the business
Whatever.
of any more hysterectomies.
That's why I need to get employed instead of being in private practice. But that's it works very well. And then you can even do the norethindrone if you wanted, but yeah.
That is cool. 1 more Lupron. So when you have an adenoma though, Acessa works in that for people that want childbearing. So the adenomas are hard to shell out like a fibroid, right? Because they're.
Yeah, I don't do Acessa, but I'm looking at Sonata. Like we're looking at Acessa, but
yeah.
we're also looking at the Sonata.
Remind me what that is? Is that the vaginal one?
Transvaginal. Yeah. It's a transuterine ultrasound. It's an ultrasound that goes in the uterus, and then the little Acessa probe goes in, and you do trans.
Okay, that terrifies me though. But let me just tell you why. So I've been doing Acessa for a while, and it's got the same little like prong things, right? So when we're doing it from above laparoscopically, we can see the prongs, and one of the checks we always have on it is to make sure the prongs aren't coming through the serosa or going into the bladder, or coming out from where we think it's supposed to be contained. And I looked at that other system. It's called Sonata.
Yeah.
And I'm like, how can they tell that those barbs aren't extending to like bowel or going outside of the uterus? Like that's the part that bothers me about it. So how are you?
I've only gone to the dinner.
Okay, so wait a
From what they said,
yeah.
What it looks like, the ultrasound is able to see the wall of the uterus and
find
the safety zone. I don't know.
So the Acessa, we're using an ultrasound too. It's a probe that goes in through a laparoscopic port, and we're tracking, the ablation zone and the prongs. But the problem is the prongs are 3-dimensional, and our sono is 2. So I mean, it's not an exact science.
So you need to be able to see the actual uterus to know that the prongs aren't messing things up.
And then, I mean, we're kind of doing the same thing from the outside in with the Acessa. So I put a manipulator with a bulb, and how we blow up with the VCare, the delineator, it has a bulb that goes in the intrauterine cavity. So I can see if I pop the bulb that I've entered the uterine cavity, because most of my patients that are getting this are fertility cases. They don't want Synechiae or Eschenmann's, right? So I've got that manipulator bulb in the uterus as a safety in case I lose a prong on my ultrasound. But going the other way, where you're not looking from above to see if anything's coming through,
it's even scary, and your abdomen's not inflated.
I know, in the bowels, and you're not in T-Berg. So I would love to know more about how the safety check on that. I'm curious about it. So, and I'm curious, why didn't you do the Acessa? Why did y'all look at it and decide no?
No, it's not that. I never looked at it when I was in Chicago in solo private practice, and now we're looking at it, but we're just starting to. You know what I mean? Like, I don't know. I just got introduced to it recently. It wasn't something that I think when they first approached me when I was in Chicago, I was in solo private practice, and like I was having a problem figuring out where Acessa fits in my algorithm, because like you've got patients who don't want to have kids anymore, so fibroids you do a hysterectomy on. You got patients that want to have kids, so you do myomectomies on them.
Yeah.
Acessa is women who don't want to have kids,
No,
but
that's
don't
not.
want to lose their uterus.
Well, yeah, that's part of it. But then I'm also using it for women who do want kids, who have like smaller, deeper fibroids that you'd end up like making the uterus spaghetti with a myomectomy. But
That's where I see its use.
yeah, you
That's
can just,
exactly like do a myomectomy and then chase the ones where if you ended up chasing everything, you'd end up with like Swiss cheese. You know what I mean?
yeah.
That's
But I
exactly where I find its use.
So that's my niche for it. But I also am seeing way more patients in their 40s, past childbearing, even their early 50s, where they just do not want their uterus out. Like they're coming in and wanting anything but hysterectomy, and I'm like, okay. Hey, Ellen, I was just looking at the chat. I hadn't been paying attention to it before, but there are 2 questions about Lupron shortage.
Oh yeah.
Yeah.
So Lupron shortage to me started when Orion came out.
Yeah.
And very strange. And if there's a Lupron shortage, you can still get Lupron samples,
Yeah.
which is more strange. So I think it has to do with Orion, but you can order Lupinetta, which is Lupron and the norethindrone packed together.
Yeah.
And there's no shortage of that.
And we were able to get generic Lupron.
Yes.
1 month at a time. So I was
Eligard?
3 months. Yeah. Huh?
Eligard, generic
Yeah.
Lupron, but that's IM,
Right.
right? And then you have to kind of convert, I guess. It's not the same amount. I was doing that before in Chicago, but it's off label because it's FDA approved for prostate cancer.
Yeah.
So you got to have them just make them aware that it's off label use, which is ridiculous.
Yeah.
You know,
That's an easy conversation.
I've used Orion at the peak of the shortage, but Lupron is back now. Oh, good. That's good. Thank you, Jane. I'm going to see if I can order Lupron without the norethindrone now. What else? I was going to ask you something. Uterine artery embolization. How often do you do send patients for that?
I routinely counsel patients for it when they come in to talk about fibroid options. I have very few that take me up on it, despite having a really great radiologist in town who was like one of the pioneers of it. He's awesome. Yeah, most patients end up deciding to do something surgical because they don't want to wait that long for it to work and to happen, or and with the small incision, the minimally invasive stuff that you and I are doing, you talk to them about a groin incision versus an abdominal incision. They're kind of like, oh, I'll just take the abdominal incision and get it out, I think. How about you?
So I've started working with the interventional radiologist, like I said, and I've been sending a couple of patients, but one thing that I'm finding very frustrating is that interventional radiologists don't usually follow up with these patients after. So you send them and then I got to see them to manage their thing. I don't know what the hell I'm doing. So wait a minute. I just sent you a patient for uterine embolization and then I'm going to manage them post-op?
Yeah.
That makes zero sense to me. So yeah, I think Acessa or Sonata as opposed to uterine artery embolization makes way more sense, because I don't know how to manage these issues that patients would have except to hysterectomize them,
Yeah. Well, that's my favorite thing to do.
Yeah, but me counseling uterine artery embolization, oh yeah, there's this other option, uterine artery embolization. It's ridiculous.
I don't go that far.
No, but yeah. So, do you do any straight stick?
I have to say very little. I can't tell you, the running joke in my operating room with my first assist is, don't ever let me schedule an ovarian cystectomy or anything that I think is just easy with a straight stick without the robot on standby ever again, because I'll do my tubal ligations and my accesses or straight stick laparoscopy, and I can take down adhesions and do a ligature, that's not a problem. But the number of times that I thought, oh, I can just do this little ovarian case straight stick, and then I get in there and I'm like, this would have been so much easier with a robot. I just pretty much book everything as a robot.
But you know what? If you've mastered one thing and you do it better than, like you're an expert at it, I get it. Like, there's nothing wrong with that. You know what I mean? Like,
Yeah,
if you've chosen the robot and that's the
fully
instrument you
committed.
chose to master, then
Yeah,
do it. You know what I mean? Because anything else is like, I do my thing and I always use ligature L hook, a grasper, and then my scope. If you put a harmonic in my hand, it's a bloodbath. Like, you're making me prone. If you don't give me the instruments that I need, that I'm constantly using, you're putting me at risk for a complication because I've
exactly.
chosen to master this. You
Yeah,
force me to use something else. Oh, whose fault is it then?
yeah.
So
I
I
agree.
get it. I respect that.
We get our routines, we get our patterns, and that's not just the choice of instrumentation, it's just even talking about our protocols for managing pain afterwards, and how the patients get counseled, and who our first assist is, and our anesthesia, and just every little bit adds up. So much of the time in academics, we're looking at like one specific variable for an outcome change. And what I've discovered in surgery, especially as we've gotten more into these minimally invasive, like advanced recovery protocols, is that it's all the little things together. Like, if you don't
Right.
prep the patient right, you don't position them right, or you change your instrument out, or you have three things that change, then you're asking for that exponential increase in your complication rate or poor outcome. So
No, yeah. So I think if you use the robot for even for the stuff that you think would be simple, I think that's justifiable, and I respect that. As long as you've mastered the instrument you chose, and you always try to improve on it, then
yeah,
that's the best thing for you and the patient, right?
yeah.
That's
Right back
beautiful.
at you. Thanks, Ellen.
What else? Anything else?
That's all I got. This was fun.
I know, right? Just hanging out, talking surgery on a Sunday night.
I know. So cool.
What else do you want to see in the group? Is there any anything that you think is missing
You know,
or you don't like?
no, I think us having this conversation, and the way we did this with you being the laparoscopic surgeon and me doing robotically, and us having this discussion where we can see our similarities and like learn from each other, is like super helpful. And that's really what I like to see in this group, is that, you put that little survey out about the membership recently about what
Mhm.
tools people were using. And I like it not being a divided into where, us versus them, or,
Oh,
that kind of thing.
like when I did my fellowship, my program director, he was, or the guy I trained under, David Zapata, he was saying that, like, if you can do it robotically, you can do it laparoscopically. There's not really much of a difference. I mean, it's the same surgery. It's just a different instrument.
Yep.
Like, I totally agree. Like I watch robotic videos and I I can apply it to what I'm doing, and I
Yep.
think it's the same. Like, you watch how I do something, it doesn't change. I mean, there are things that you can apply to what I'm doing. It's the same thing, right?
Yep. Yep. Same
And
thing.
and I think that, like, there is that division of robotics versus laparoscopic, and it's kind of like a pissing contest, but
Yeah.
it
It's
doesn't
just
make any sense.
not necessary. So I love that. I think you're doing a phenomenal job with the group and the page. I don't know what made me chime in on this one in particular. I was like, oh yeah, hey, I'll talk about that.
You said, well, let's hang out. I said, let's do it. Like, I started doing these Zoom things because with everybody in COVID and being like secluded, I figured, like, I've got like the kids, I gotta finish homework with my son and spend family time, but there's some people that don't have that right now. So
Yeah,
I think
yeah,
it's important for us to kind of, like, maybe this is something that's making a difference in somebody's Sunday when they weren't doing anything because they're quarantined you
yeah.
know
I hope
so
so. I'd like to see us figuring out how to do more mentoring of less experienced or younger surgeons. My whole passion is to create more surgeons like us who are pushing towards smaller incisions, shorter length of stay, no narcotic surgeries. And, everybody's just not that comfortable doing it. So anytime we have the chance to be like, okay, what little tricks or tools can we get you to get one more patient minimally invasively instead of open, that's whatever we can do to keep that going is important, I think.
One thing about like fellowship and learning things and kind of getting to where we are, like, so my training was, I did 2 years of general surgery, then OB-GYN residency, and then straight stick laparoscopy with this guy in Chicago, Chuck Miller, and then a fellowship in robotics. And then I come out of fellowship trying to use the robot, but nobody's giving me enough block time because I'm brand new. So,
oh no.
I didn't really have, access until like the schedule was empty. One of my houses had a robot, the other one didn't. So I kind of started using this mini laparoscopy stuff, and nobody taught me how to do it. I kind of just did it and worked on improving it. And I think that should be the case with all of us. Like, we learn from our training, but what you were taught in your training has nothing to do with what you're doing now, right?
Yeah.
Like your mentors would be like, where the hell did this come from, right?
Exactly.
And I think that's the case for all of us. So like, you don't need a fellowship. Like what you learn in your fellowship or in your residency is not going to have anything to do with how you do your surgeries when you're out, because we all have our own styles, right?
Yep.
We just have to constantly like improve how we operate and like have us be our, like toughest critic. You know what I mean?
Oh, we are.
Right. Like, do you record all your surgeries?
Oh, no, I don't.
So like I record all my surgeries and watch it over again.
Yeah.
Damn, man, why did I do it that way? Or I could have done it better. Or why was this case so hard?
Yeah.
And then see how I could have done it better. And like, I post it to you guys so you guys can tear it apart and tell me how I could do it better. And I learned,
I think you're very brave. I appreciate the vulnerability for as much posting as you do. And I have to tell you that my skin's not as thick as yours. Oh, there's another question.
Trust me, I cry every time somebody says something bad. Janie asked a question. She says, I may have missed this, but where do you like to place your robotic ports for these big uteri? I sometimes have issue clashing with my fourth arm. I think that's your question.
Okay, so great question. I put my scope port through a 12mm balloon trocar in the umbilicus, so I do a cut down for that. Then after I look in and we fill the abdomen, because you can see how much distension there is and really what the anatomy looks like to get to your vessels, then I decide whether my robotic ports are going to go 1 centimeter below and 8 centimeters lateral, which is my traditional placement, or whether I'm going to do more of an M where they go a little bit above the umbilicus so that I can get around the fundus of the uterus. I don't use a fourth arm almost never anymore, but I do use an assistant port, and my assistant port goes very far down just above the right hip bone. So if I was going to do a fourth arm, I would do a fourth arm on the opposite side. It would go like 1 centimeter or 2 above the ischial tuberosity of the hip bone and very far lateral, so that you don't have that external collision issue.
What's wrong with the fourth arm?
I just don't need it. So between my 2 arms and the assistant port, like on a big uterus case, having another instrument in there doesn't help. I think if you're going to do a case without an assistant helping you with rotation and you want to use it for retraction or rotation, that might be useful. But I use a first assist on all my cases. So.
Does your assistant use a single tooth tenaculum to grab the uterus, or?
Davis and Geck, and she'll commonly grab it. So I have one person who stands on the patient's right, and she does the uterine manipulator with her right hand and the assistant port with her left. And so she will grab like the round ligaments at the cornu to move the uterus around for me, or lift it up if I'm trying to do dissection underneath it. or suction, but she's doing both the manipulator and the assisting from that side.
Okay. Yeah. So I don't like those single tube tenaculums.
Yeah, I don't either. They bleed too much.
Oh God, all hell's breaking loose with the blood and
Yeah.
but all right. Any other questions? All right. Well, what you call it? I think that's it, Sue. It was so much fun hanging out with you.
I love hanging out with you, Ellen. Yeah. We have to. Have a great week.
Yeah. Show some videos. Post some hysterectomies.
Okay, I'll do some videos for you this week, I promise.
All right, and I'll come back with a bloodbath, just so people don't get stuck on somebody else's video. Okay.
Fun, right?
Yeah, just for the hell of it. Thanks for hanging out. I appreciate it.
You're amazing. Thanks for doing this. Bye.
All right.
See ya.
Take care, guys. Thanks everybody for showing up. Good night.
Good night.